and welcome to the third Dr. C. Gopalan Memorial Webinar. The theme of the webinar today is Health Action Plan to Mitigate Health and Nutrition Problems Associated with Climate Change. Until about a decade ago, global warming, climate change, and its impact on human nutrition, health, and quality of life were all debated issues, very hotly debated indeed. Now there is clear evidence that the mean global temperature in the last 7 years have been the highest temperatures ever since recording of temperatures began. No part of globe is free from the rise in temperature. The results of rise in temperature vary in various parts. We experience heat stress. Many parts of the world experience forest fires. Melting of polar ice caps results in rise in sea level. There has been a steep increase in frequency, duration, and intensity. Sorry, I believe audio is not clear, and I hope it is clear now. There has been a steep increase in frequency, duration, and intensity of disasters attributed to the climate change related extreme weather events, such as cyclone, landslides, torrential rain related flooding, especially urban flooding. All these disasters take both their human and economic tolls. At the other end of the spectrum are drought, water scarcity, soil erosion, salinity, all leading to lower food production, increase in food insecurity, undernutrition, and ill health. Three broad categories of action are required to combat climate change and its adverse consequences. First is to cut the greenhouse gas emissions. The second is to develop technologies for adapting to climate change and rising temperature. Third is to evolve and implement programs to mitigate the adverse consequences of climate change on health and nutrition. Global efforts are critical for slowing down the further rise in greenhouse gas emissions and consequent rise in global average temperature. But each country will have to evolve and implement locale specific interventions to reduce emissions, to adapt to climate change, and mitigate the adverse consequences of climate change. India, and for that matter, entire Asia, is one of the parts of the globe that is most vulnerable to climate change related disasters, resulting in acute food insecurity, as well as drought-related fall in food production and increase in chronic food insecurity and undernutrition. In India, the Prime Minister's Council for Climate Change constitute a mission on health for coordinating the efforts to deal with climate change-related health and nutritional problems. An expert group was constituted by the Ministry of Health, and this prepared the National Action Plan for Climate Change and Human Health. The National Center for Disease Control has been the nodal agency for implementation of this. They had selected 17 centers of excellence and have developed a detailed health action plan, including training plans, assisting state governments for developing their PIPs for health sector to mitigate climate change associated health and nutritional problems. In today's webinar, there will be 4 presentations. The overview on health action plan for combating climate change related problems will be presented by Dr. Akash Srivastava, Additional Director and Head of the Center for Environment, and Occupational Health and Climate Change and Health from the National Center for Disease Control. This year, all of us suffered through hot and prolonged summer. Dr. Dilip Mavlankar, Director, Indian Institute of Public Health, Gandhinagar, will be sharing his experience regarding prevention and management of heat stress in sun-drenched India. Dr. Lakshmaya, Scientist G, and Head of the Division of Public Health Nutrition from the National Institute of Nutrition, Hyderabad, will make a presentation on nutrition impact of climate change and options for action. The last presentation will be from NFI on climate change and food security in India. We have slotted sufficient time, 10 minutes, for audience interaction of each of these presentations, and we look forward to interactions through chat. We hope that all of you will participate intensively in the interactions so that we do have an excellent interactive webinar. I must tell you that one of the important elements of this is that thanks to the assistance from NCDC, several of the state nodal officers for climate change and health have also logged in, and therefore this is not only an academic and research seminar, but would also further state action plan for health and nutrition so that it becomes a part of their state PIPs in the year 22-23. And hopefully implementation of those action plans will begin in the year 23-24. In India, most things take time, but that time is well spent because we will be able to act according to a plan on well-directed lines. The first presentation is by Dr. Akash Srivastava on Health Action Plan for Combating the Climate Change Related Problems in India. He will give us the overview. Dr. Srivastava.
Very good morning to everyone, and thank you, Madam, for providing us this opportunity to be present in this important workshop webinar that has been organized on the subject of climate change and certain aspects of heat and nutrition and food security, which are very critical components of matters related to climate change. I would like to share my presentation. I hope it's visible on the screen on a full screen mode.
Yes, it is visible, clearly visible.
Thank you. Thank you. So, I today am speaking on behalf of the National Program on Climate Change and Human Health, which Madam introduced in her talk in the morning today. And way back in 2008, when the Prime Minister's Council on Climate Change came about, it was having 8 specific missions addressing very critical areas that were relevant to climate change and mitigation components. Somewhere in 2015, a need was felt that there should be a mission on health, considering the huge impact climate change has on health and requires to be addressed in a more detailed manner, and therefore a separate mission was proposed. The Ministry of Health and Family Welfare, Government of India, was assigned the nodal ministry to implement this mission, while Ministry of Climate Change continues to be the nodal ministry for climate change and oversees the work of the Prime Minister's Council on Climate Change and coalition of all the missions. This particular mission was being addressed by Ministry of Health and Family Welfare. The National Center for Disease Control has a center here on environmental, occupational health, and climate change, which assigned the responsibility to provide technical support to the ministry in delivering this mission and its goals and deliverables and objectives. To begin with, it was proposed that we should try to understand what are the challenges in the country in regards to climate change and human health. And four experts were to be invited from all parts of the country and asked them to guide the ministry on how we need to proceed forward. Under the chairmanship of Professor V. Katot, who was the former Director General ICMR and Secretary DHR, a national expert group was formed in the year 2015. And after several meetings and inputs by uh, many experts from various subject areas, a national action plan for climate change and human health draft was prepared. And ever since it undergoes a revision based on the inputs that are provided onto the draft. It is available on the website of National Center for Disease Control, and periodically it's updated. It was revised in 2021 when the country was going through the pandemic, and there were areas related to pandemics that were suggested to be included in the draft. The goal of the National Action Plan for Climate Change and Human Health is to reduce injuries, morbidity, mortality, and health vulnerability to climate variability and extreme weather events. Now, one of the challenges before the Ministry of Health and Family Welfare was that should it be implemented from the center, or should it be implemented by the participation of state governments as well? And considering that the climate variability in the country like India, which has a very large uh, geological presence with different climatic zones, it was necessary that all states and districts could participate so that they could attend to the specific challenges that different states and districts would have depending upon what climatic zones they fall in. And therefore, the Ministry of Health took an initiative that we will introduce it as a health program under the National Health Mission umbrella, which is a platform existing with the Ministry of Health and Family Welfare when it wants the states to take up a health subject in a mission mode. And therefore, this program was proposed under the National Health Mission of the Ministry of Health and Family Welfare, went through the process of review by experts, and the Honorable Minister approved it in the Mission Steering Group of National Health Mission in the February 2019, and thus came in the National Program on Climate Change and Human Health, which has the objective to deliver on the goals and objectives of the National Action Plan of Climate Change and Human Health, with a funding mechanism in which center and states share under the NHM umbrella. As we know, climate change has a huge spectrum of impact on health, and we can see that issues of rising temperature and extreme weather result in a spectrum of problems ranging from severe weather, extreme heat, air pollution, change in vector ecology, increasing allergens, water quality impacts, water and food supply impacts, environmental degradation, all of which will further relate to a lot of diseases and health conditions that require to be addressed. The program thought that each of those will be addressed, but probably it will not be possible to address all of these at the same time. Some of them will be addressed more upfront, and the others will work up. And that's when we decided that we will identify centers of excellence. These are the premier institutions of national repute which work in specific health outcome areas and would be able to guide the program on how we could address them. The five major pillars that were identified, irrespective of what health outcome that we were going to address and became the key objectives of the program, is first to generate awareness around that subject. So the awareness around climate change and its impact on a particular health outcome, that would be the first objective in the program. And we deliver that through IEC material and IEC campaigns. We hold sensitization workshops and issue advisories from the headquarters to the state governments, and then request the state governments to go on to issue advisories to district governments and to health facilities and the people. We also work on the second pillar, that is capacity building, that essentially includes trainings of the health workforce, medical officers, and other health professionals, and also develop guidelines and manuals and help these workforce understand what they can do, and also have knowledge exchange workshops from time to time wherein health professionals can learn by sharing new work and experiences based on their work that they have done. The next pillar is strengthening of the health sector preparedness. The first part of that is developing health adaptation plans. As we realize that there are so many climate sensitive health outcomes. For each specific health outcomes, health adaptation plans were to be developed. The centers of excellence were requested to develop a generic health adaptation plan, which we further share with the state governments and ask them to develop their health adaptation plans, and then request the centers of excellence to look into the state health adaptation plans and provide feedback so that they can be improved. We work on area of vulnerability assessment. Certain health outcomes require enhanced surveillance that helps to provide data that can guide us as to what are the trends of those health outcomes with changing weather variability. For some of the health conditions, surveillance already exists. In those conditions, our objective is only to ensure that we include environmental parameters and meteorological parameters in the existing surveillance system. So we are working with those programs which run those surveillance to include meteorological and environmental parameters into existing surveillance systems. But for certain health conditions, there was no existing surveillance system in the country. So we introduced either a sentinel surveillance or passive surveillance to address those issues. Two of the conditions that we have introduced surveillance is First, on the air pollution related illnesses, we have a sentinel surveillance now operational in the country with over 16 states working with about 60 hospitals where we are getting reports on sentinel surveillance on air pollution related illnesses. And then also we have in 23 heat vulnerable states, we have heat related illness and death surveillance going on in the country. Then we work on early warning alerts and response system. The idea is that wherever we can, we would like to bring the available information from meteorological department and pollution control boards and other organizations, alert related to environmental conditions, to the health facilities and also to the population, so that this information is timely available with them. And also certain conditions like extreme weather events. On the other hand, we are also working on providing alerts related to threshold of health conditions related to these environmental conditions. So both environmental alerts as well as health alerts related to environmental conditions. That's the objective in working in area of EVARs. The last here is health system resilience. While health sector is probably not a very big sector that will be responsible for contributing to greenhouse gases, but all the same, it is still not a very small sector either. So the objective here is to ensure that we have a green health sector and a health sector that is also resilient to the impacts of extreme weather events. We are familiar that in cyclones and floods and certain extreme weather events, we have a loss of health facilities that leads to loss in health service provision to affected families. So these are the areas that we are working in. The another objective under the program is collaborative partnership. As climate change is a subject that is intersectoral spread of challenges and efforts requirement, we have very recently in the year 2020 constituted a national steering group of environment and health, wherein both the Secretary, Ministry of Health and Family Welfare, and Secretary, Environment and Climate Change Ministry have consented to co-chair, and under the chairmanship of both the secretaries, a joint secretary and above level officers from several other 14 to 15 ministries are part of this national steering group platform. That's where we discuss core issues of environment and its impact on health and how the ministries can contribute towards that. We also collaborate with other missions under the Prime Minister's Council, other national programs, both in the health sector and beyond the health sector, as well as organizations, government organizations, non-government organizations, civil societies, and United Nations bodies that work in subjects related to climate change. Indian Council of Medical Research is the nodal agency for medical research in the country, and they have been assigned the responsibility to steer research for climate sensitive illnesses. They have constituted a high-level committee that looks into what are the subject areas that needs to be addressed in climate change and health, and then call for proposals to take up research in those given subjects. So in this figure, we can see how the organogram works. At the district level, there is a district program officer assigned in all the districts of the country in the program, looks into the program. And the work of the district level work is overseen by the district task force chaired by the district magistrate. At the state level, again, we have a district state level program officer who is supported by a state environmental health cell in the Department of Health of the given state. And the work of the state is overseen by two bodies. The first is the multi-sectoral task force, which is presided by the MDNHM or the Principal Secretary Health of the given state. And then a higher body, which is the governing body, which is supposed to be presided by the Minister of State, the Minister of Health in the state, or maybe Principal Secretary in his absence. So that body, those are the bodies that bring together other sectors also and help the state program officer in work that would involve other sectors as well. At the central level, the headquarters of the program is situated at National Center for Disease Control, and then we work with the centers of excellence that provide us technical support in area of research. It's the ICMR that we link with. We also link with other ministries, other programs, and other organizations. We report the work, and our job is overseen by the Ministry of Health and Family Welfare, and which is reported to the Prime Minister's Council on Climate Change. So as we can see in this slide, there are all the health conditions that we have identified to work on the left side. And on the right side, the centers of excellence are the national premier institutions in the country, which have consented to provide us the support. They help us in drafting of the adaptation plan in the given subject areas, help us in developing IEC content, help us in developing training manuals, and also supporting the training of master trainers, and then also providing concepts on how surveillance systems can be established, identifying case studies, good practices, documenting research work in the given subject areas, and giving us assistance on how to move forward in the given subject area under climate change. But a glimpse of some of the work that we have done, this is regarding the awareness. We organize activities in the health center. We organize activities in vulnerable population, in children, in slums. We also have IEC contents, and also occupational risk groups are also provided sensitization and awareness. Some of the IEC contents, for example, in air pollution that were developed under the program, and these are the IEC contents in same on air pollution developed by the state governments, and all states work together very seriously on this subject with the related to climate change and environmental health issues. Capacity building related works that we are doing, officers training, program officers training, webinars, field visits, knowledge exchange workshops, training manuals and infographic manuals for communities and healthcare workers, and review meetings of the program officers. These are some specific workshops that we have conducted this year, which has the purpose is to bring all the state program officers to the state where some good work has been done in a specific area under the climate change and health. For example, we had a workshop in Kerala this year. We got together to understand how the government of Wayanad district in Kerala responded by developing flood-resilient healthcare facilities after the floods in Wayanad. We went to Ahmedabad this year in the month of June with all the state program officers to understand how the government of Gujarat, the IIPH Ahmedabad, and the Ahmedabad Municipal Corporation work together to fight against impact of heat. Similarly, very recently, we had a workshop in Raipur, Chhattisgarh, to understand how community workers in Raipur are leading the challenge against air pollution. And very soon, we are planning to have a workshop in Bhubaneswar to understand how Odisha had designed to fight cyclones. And these are some of the health sector preparedness and strengthening work. We're developing national level health adaptation plans, one available on air pollution, another on heat, and the others are also now almost in process of finalization. The advisories, the early warnings, EWARs, surveillance, as I mentioned, on air pollution and heat, and vulnerability assessment work, and also as the green and climate resilient healthcare infrastructure. Under the NHM, we have provided support to the state government and guidelines on how to work towards energy efficiency, guidelines for audit and LED replacements for lights, provision for solarization, solar panels on healthcare facilities, rainwater harvesting, and retrofitting such as cool roofs and flood resilient measures. So funds have been provided under the center and state fund sharing mechanisms in the program, and targets have been provided to the district government along with guidelines, and the work is going on. There's also some of the work that relates to preparedness in hospitals, ensuring that the certain conditions that are life-threatening for them, there is adequate facilities. For example, with growing challenges of heat, uh, telling the governments how they can develop a heat stroke ward and provide facilities of awareness and therapy in community health centers related to heat. So this was some of the work that I, in glimpses that I tried to provide here on what we are working in areas related to climate change and health under the program. That's it. Thank you.
Thank you very much, Dr. Srivastava. That was indeed a really very comprehensive overview, and we are extremely grateful to you for having provided that overview so that the rest of the presentation, which deal with specific subjects, can be uh, viewed in the context in which these were done. This is the time for questions. There are two mechanisms by which you can ask the questions. You have maybe 7 to 10 minutes now. One is to raise hands, the other chat mechanism. Perhaps the most efficient is the chat, but both options are there for you. As I said earlier, one of the most important things for us is the mechanism by which participants do participate and raise questions and get their answers from the people who are really here to answer your questions, so that you will also join the movement. Time is critical, and we can't afford to lose any more time in combating the adverse consequences of climate change on nutrition and health. Any questions? Okay, Dr. Akash, I will begin. I have a one. It has been worrying me for quite a while that you have outlined that multiple ministries are involved, multiple programs are involved. And actually, the states will start putting in their state program implementation plan the climate change component. And that is the reason why you had organized so many workshops and dealing some specific aspect. What has been the response that you got in the very first year? That's always going to be the least because people will have to get used. And the second worry that we have is always that there is no line. There is no line called as heat stress management. There is no line called as, let us say, food security management. And without a line budget, very often the finance and administration in the state government gag at introducing the newer programs. What are your methods by which this initial hesitancy can be tackled?
Okay. So when we started with the program and very first year of introduction of the program, we realized that the general understanding, even in the people who are from the medical sector, who are also program officers and have been around for a long time, their general understanding might be there of climate change, but perceiving the threat of climate change as a real-time threat, that perception was very weak. And it always seemed to them it's something that is quite distant. It is something that is not in my immediate sphere of life related matters, and therefore as and when the authorities will decide that it is high time to work on it, we'll look into it at that particular point of time. And we realized that one of the reasons probably is because most of the people who are today in service never addressed this subject in their education when they were completing their graduation, post-graduation, or courses after post-graduation. It's a relatively a very new subject area for them. And that is one of the important reasons that a lot of sensitization, a lot of work goes on right now to bring the people to understand that, yes, this is something that which is very serious and we need to act on. The another challenge is that the health sector always feels that, well, we have too little to do because probably the work lies in the hands of the climate change department and then the environment department. It's they who have to look into mitigation methods, and if they're not doing anything, we can hardly do much about it. So we better concentrate on subjects of malaria, tuberculosis, and RCH, which are more important for the health sector to deliver on. So these are two things, and probably this is also the mindset that is of the senior administrative officers who are in the lines of administration and bureaucracy, and probably that also relate to why not enough funds are allocated, not enough manpower is provided to address the program at the state level. So there has been a requirement to take a lot of pushing to make the state accept that there are things that we need to do and we need to do right now. And many of the champions are available in the country who are already doing very good job. We can go look at it, understand, and find ways to address this. And we should not try to postpone and be lenient about this matter. And I believe that there are existing platforms already. There is a Ministry of Climate Change and there are interministerial work, but probably there needs to be more emphasis among the policymakers to take this in seriousness. We have international documentations coming up where governments pledge to take these initiatives, but when it comes down to translations on level of deliverables, people go back to their routine methods of addressing issues. So some innovation, some more policy drives, and are probably needed. And the financing is a huge challenge, and it's not something that can be addressed in a very limited amount of money, because the extent of the problem is huge, and there has to be identified financing and funding mechanisms to address this challenge.
There are three questions in the chat, which
Yes.
I would now put up to you. Dr. Madhavan Nair from NIN, do you think that pandemics like COVID-19 have anything to do with climate change?
Well, uh, this pandemic was basically a zoonotic disease, and in larger context, considering that the interaction between man world and the animal world is now increasing, we have more chances of getting in contact with infections that are harbored with the animal population, which were previously not harbored by the human population. And with change in the climate, there is also the animals finding threats in their existing environment, try to might to change their uh, usual places where they tend to habitat. And this change in habitation brings more interaction and provides for easy opportunity of transfer of viruses. And also in specific COVID pandemic, another important role that was recognized was that the areas which, since it was a respiratory infection, the population that lived in heavily polluted environment were the ones that continued to face this challenge for a longer period of time, because respiratory infections over compromised respiratory system made recovery from the problem more challenging. So these were the two major issues that I'm listing, though there would be many other issues that we can speak of. We can't hear you, madam, here.
Dr. Lakshmaya had raised this question. ICMR has been, you said that ICMR has been given the responsibility to take up research activities, especially impact of climate change on health and nutrition. What are the initiatives that has been begun by ICMR?
So what I am aware of is that there was a high-powered committee in the ICMR, and it was chaired by the director, All India Institute of Medical Sciences, Delhi. The objective of this committee was to identify areas of research and relevance that the ICMR would work on. Since COVID at that point of time was also an important parameter, so a lot of suggestions was related to COVID and health as well. But there are specific subcommittees within the committees which also work on specific subject areas. One of the subject areas that invited calls for proposal was the subcommittee on climate change and vector-borne diseases, and that was chaired by Professor V.M. Katoch, who was a former DG ICMR, and there were a huge number of proposals. I was an observing member in that committee, and they are in the process of shortlisting those proposals. in context of nutrition, I'm not aware of any call that has been initiated, but I would request the concerned scientists who understand the challenge kindly address this issue with the ICMR headquarters, and I'm very sure that they will make the necessary initiative in that matter.
Thank you. The next question is from Dr. Venkatesh. Dr. Venkatesh is formerly from NCDC and later he is retired from DGHS. There are some areas of overlap between diverse activities and institutions involved. Example, nutrition by NIN, food security by NFI. How are these to be coordinated for effective outputs in terms of action plan and IEC?
Well, the NFI is primarily addressing the challenge of food security and major policy issues related to how the deficit of food and energy deficit would probably challenge the society. And the Institute of NIN is primarily addressing issues of nutritional illnesses and how health sector can respond to those nutritional illnesses in context of climate change. And yes, there is some areas of overlap, but eventually all programs are proposed to be delivered at the state and district level, where the mechanism is more or less the same. So those overlaps will be eased out at the delivery points. And we both have we have today NIN and NFI today in the webinar, and they will be able to better address this question further. Thank you.
Thank you very much. The last question is Mr. Gautam Sen.
Good morning to everybody. Thank you, Madam Prema. My issue is that there is a need for adopting a clusterization approach, because the climate impact is, like adjoining states have a same sort of climate impact over and above the time. So this aspect may be kept in the reckoning. Another issue I would like to suggest is from the point of view of finances, that is, there may be a normative approach, that is some element of finance for combating climate change and impact on health and other areas of nutrition and sustainable livelihood is kept in view. Thank you.
Thank you. Thank you.
Thank you. If there are no more questions, may I thank Dr. Akash Srivastava for having given us a very comprehensive, clear overview, which makes our life somewhat easier in terms of this webinar. Because now we will slot each presentation into, okay, Dr. Mavlankar will talk about heat stress, Dr. Lakshmaya will talk on nutrition problems, and I will talk on food security. They will ultimately get integrated at some level at the states, and more importantly, at the districts. Thanks a lot, Dr. C.
Thank you.
May I now request Dr. Mavlankar to make his presentation. I would just like to put one point before he begins. Very often, events overtake us and then we respond. But in two areas, one is food security, the other is heat stress. We had plans how to prevent it, how to manage it, how to minimize the adverse health consequences, long before climate change became the major issue that occupies everyone. So, the heat stress, this is the ideal time, the year full of horrible heat stress across the globe. And may I request Dr. Mavlankar to take us through.
Sure. Good morning, everybody. Can you hear me well?
Yes, we can hear you very well, Dr. Mavlankar.
Let me share my presentation and we will begin. So first of all, thanks very much to Professor Prema Ramchandran and Nutrition Foundation of India. It is a delight to present to nutrition scientists and interested people on this issue, which I have presented to many audiences, but first time to the nutrition community. So this is a collaborative work which we did over last almost 12 years to understand what is happening in Ahmedabad city during heat waves, plan an action plan, and then see what is its impact and the national scaling of that action plan. And all the above ones, I will introduce all our partners at the end of the presentation. I have for half an hour, no? So we will go up to 11:25, 11:20 or something, and then I will stop. And if we have any questions, we will answer that. So just a brief introduction of Indian Institute of Public Health. It is the first public health university of India, started by Gujarat government and Public Health Foundation jointly. We offer two master's program, Master of Public Health and Master of Hospital Administration, and a PG Diploma of Public Health Management, which is largely meant for the government health officers. And we work in many areas which are shown here, including environmental and occupational health. And this heat health work is part of this environmental and occupational health. The heat health and its killer potential was introduced to the world through a major heat wave in the city of Chicago in 1995. Chicago, as you know, is a very cold place. But during the week of 11 to 27 July 1995, there was a major heat wave. If you see the green line on the top, which normal temperatures are 80 to 90 degrees Fahrenheit, it reached to 105 degrees around 11th, 12th of July. And the mortality, all-cause mortality, which is the red line, which is around 150 to 175 or up to 200 every day in Chicago, touched at the peak heat, just after the peak heat wave, almost 500 deaths in one day. And then it came down, and the total additional deaths were 700, and heat related, which were certified, is 465. So just 1 week of heat wave killed 700 additional people and 465 because of directly because of the heat wave. So this was the first time that such a great heat wave related mortality was noticed by scientists, studied and reported, and the paper was published in New England Journal. Not only that, what happened in that week was something what was happening in COVID. Hospitals and emergency rooms in Chicago were full. This is a picture of Chicago emergency room, which are normally not so full. Patients are so close to each other because there were so many patients the hospitals couldn't handle. People who were affected were old, who were isolated, who don't had any social support, and without cooling, because Chicago, nobody uses air conditioning. It is always heating that people have, and no support. And as a result, after that week, Chicago had to develop mass graves because so many people died who were unidentified, their relatives were not traced. They had to dig a mass grave and bury all of them. So this was in some sense the first major heat-related emergency recorded in the Western world. Following that, the 2003, there was a major heat wave in Europe. Are you able to hear me?
Are
you able to hear me?
I am able to hear you quite well.
Okay. Now, Dr. Tang, I think, has some personal discussion. So, okay.
Please mute everyone.
Yeah. So
All of the participants, please mute your uh,
yeah,
devices so that
now,
others can hear much better.
yeah.
Thank you.
So 2003, there was a major heat wave in Europe, about a 3-week heat wave, which killed 70,000 people additionally, additional deaths, all cause. And this is just a graph which shows how the graphs look. This is more detail of that. If you see the left side map, it shows you standardized daily death frequencies in Western Europe. And the main red areas are France and Spain and parts of northern Italy. In France, the graph above shows that daily deaths increase was almost 2,200 when the temperature, it was a 3-week heat wave and temperature had just reached the maximum temperature on the right hand side. If you read, it is 35 degrees or 36 degrees centigrade, and nighttime temperature reached 20 degrees centigrade. So in some sense, it was a cool time as per Indian standards, but that was very hot in France and Europe. And that time also nobody had fans or cooling devices, and many old people died in France and Western Europe. So this was another wake-up call where such a large-scale mortality happened, and that is why WHO, WMO, World Meteorology Organization, and WHO started looking at this, developed joint activities and programs, and many international agencies started looking at this issue of mortality in cold climate countries. If you look at Ahmedabad, I lived here since 1960s. I spent many summers at my mother's place in Pune in summer vacation. I still remember in the 60s winters, we had to have coal-fired sigri to keep us warm, and we used to use big, thick dulai quilts. And winters was like 1 month, 2 month winter. Now, if you live in Ahmedabad, the winter is 1 week or maximum 2 weeks. You need some kind of sweater. Many people still use ACs in the winter because the temperature, and this graph shows you average temperature increase of Ahmedabad. And sometimes even the global discussion is about 1 degree, 2 degree, which is average increase. So the maximum minimum temperatures will increase substantially. I'll come to it. But this is a place where data is stored called hot HAPS. You can see your own city's temperature, how it changed over the decades. Now we come to the Ahmedabad heat wave of 2010. This is just the graph of maximum daily temperature as reported by IMD of Ahmedabad city. In 2010 is the top red line, and the black line below is the average of 2009 and 2011. So 1 year before and 1 year after the heat wave. So normally at that time, the temperatures were around 42 to 42 degrees in May, most of the days. But if you see this May of 2010, the temperatures on 13th, 15th May reached almost 44 degrees. And on 21st of May, it reached 47 degrees and then came back. So it's a clear major heat wave. And this was, Ahmedabad is already hot and heat waves have been there, but this was a recent one which we and everybody noticed, and much higher. Of course, such, if you ask IMD, such temperatures were reached. It is not unheard of. In 1920s, such temperatures were recorded in IMD station in Ahmedabad. Now, what we did was, after a workshop of scientists, public administrators, academics in 2011, facilitated by an Indo-US grant, we started looking at the daily all-cause mortality of Ahmedabad city. And Ahmedabad has fairly good birth and death registration. So upwards of 99% deaths are registered. You can't burn a body without registration in the crematoriums and in the burial ground. So, and those deaths are daily totaled and reported to the health officer. So they have daily totals of deaths. So we correlated that, and the black line graph and the red line graph are temperature graphs, where on the right hand side you will see the temperature uh, calibration. On the left hand side vertical axis is daily deaths. Now Ahmedabad at that time had about 50 lakh population, so roughly about 100 deaths were happening every day in Ahmedabad. The orange solid area is the daily average counts of death for 2009 and 2011 averaged. But 2010, if you see the vertical beige color bars or brown color bars, starting with 19th of May, it started jumping. It went to 150, then 175, then on 21st of May, 310 deaths were recorded. And then gradually coming down on 27th, 29th, it became normal. So if you add up the total excess mortality in the week of the heat wave from 19th to 27th, it is roughly about 800 deaths more than what we would have expected. And at that time, there was no other epidemic, no other reason for this excess mortality except the heat wave. There was no other epidemic going on. If you add up the excess mortality of May 2010 and compare it with the mortality of 9 and 11, 1 year before, 1 year after, we get excess mortality of 1344, because there was a small peak of heat wave in around 13th to 15th May. So this was the first time that using very simple death registration data and correlating it with the daily temperatures which IMD is producing, we could show that even in a very hot acclimatized city like Ahmedabad, excess mortality of this proportion is happening. Normally what happens is you read in the newspaper that one policeman died, one laborer died, one somebody died. So you read such reports, but one couldn't imagine that 800 people died in 1 week of excess mortality during the heat wave. So that in some sense made Ahmedabad Municipal Corporation aware. Of course, they knew, and there were videos and local channels showing that hospitals were overwhelmed. Lot of people were buying ice. They're trying to cool their relatives who were sort of suffering from heat stroke. We also looked at the data from, we have a EMRI 108 ambulance service, which has a very good computerized data. This is just one cause related to heat wave, unconsciousness. So they record what is reported when the ambulance picks up as a symptom. So if you see the 2010 data for April and June, every day about 10 to 20 people are picked up for unconsciousness. But in the heat wave, this went up suddenly to about 60, 55 people picked up on one day. So clear increase in unconsciousness cases. Similarly, there are data I didn't show of other reasons, high fever, etc. also jumped like this. So there is also morbidity data. Unfortunately, we don't have so much hospital data to show you. So the point I'm trying to make, and I'll show you in the next slide, that heat wave deaths, not only in India, but in Chicago as well as in Europe, are roughly like an iceberg. What gets reported in the public systems are 1/10 the visible part, which is what is generally called a direct heat stroke, which is somebody who is young working in a hot sun gets heat stroke and dies, which is very clear. But majority, 90% of the deaths are in older and comorbid people, which may develop complications 1 or 2 days after the heat wave time, or at night or next day, etc., because their body systems are already weak and the heat wave puts additional physiological stress in terms of rapid circulation to cool the body, and that is how systems fail and they die. So this is, I think, an important thing to remember, which many public administrators, doctors, other people, even epidemiologists don't fully understand unless they work on this issue. Maybe it's like malnutrition. You see very few deaths because of malnutrition, but it contributes substantially to the other morbidities and mortality. The other thing we did was to correlate the daily number of deaths with the maximum daily temperature. This is just a simple scatter plot. The reason this was done to see where we should have a threshold for the alerting system, because most of the heat action plans we saw from other countries had alert systems. So if you see this, and there's not much statistical analysis we have done, but roughly we divided the maximum temperature categories into more than 41 degrees, which is yellow alert, more than 43 degrees, which is orange alert, and more than 45 degrees, which is red alert, where the temperature went quite high. And these were used as cutoffs for our heat action planning. The other analysis, which some of you are more scientifically oriented scientists, I wanted to show, which we did about 3-4 years after the heat action plan work started, is to correlate not only the maximum temperature, but also the minimum temperature at night to see the effect of combined effect of maximum and minimum temperature on mortality. So this graph shows you the effect of maximum and minimum temperature on mortality. The left hand side graph shows that if the maximum temperature is less than 43 degrees, then the minimum temperature doesn't make any difference in mortality. The three graphs, verticals, are minimum temperature less than 28 degrees, 28 to 30, and above 30 degrees is the red one. Now, if the maximum temperature is between 43 and 45 degrees, then you start seeing this step ladder pattern, where as the maximum temperature goes, minimum temperature goes up, you have higher and higher mortality. So if the minimum temperature is less than 28 degrees, you have only 93 deaths on an average. If the temperature goes above 30 degrees, you have 166 deaths. This is Ahmedabad 15-year data. But if the maximum goes above 45 and the minimum still remains below 28, still mortality increases, but very slightly, 108 deaths on an average. If it goes between, minimum goes between 28 to 30 degrees, it goes to 138. But if it goes to above 30 degrees minimum temperature and maximum is above more than 45 degrees, then you have 264 degrees. So what it shows, and this is again, same thing is seen in Europe. So it is not our own anything very original, but we are just showing what happens in Europe is also happening here. That if it is a hot day, but cool night, mortality doesn't increase because body gets time to rest at night and cool. And again, next hot day, they can suffer. But if the day is hot and night is also hot, or previous night is hot and next day is hot, then you will see much more mortality. And I just want to show you, I didn't put the slide, this year's at least surface temperatures recorded in Delhi at night were about 40 degrees, which is unbelievably hot. I am showing you 30-degree night temperatures killing people in Ahmedabad. I don't know if Delhi, what happened during this summer, and if somebody is correlating this daily mortality and temperature in Delhi. There is also something called urban heat island effect. Downtown, or there are where tall buildings, less trees, more pavements, more heat absorbing areas are much hotter, 5, 6, 7 degrees hotter than the surrounding rural areas. Some of the recent I saw, I think in Portland, there's an Indian scientist who have measured 25-degree Fahrenheit, not centigrade, difference between the richer neighborhoods with lot of trees and poorer neighborhoods with less trees. So this is another. So what we really read in the newspaper is the airport temperature, because most IMD stations are at the airport. So in some sense, the city center may be already 2-3 degrees hotter than this. Now coming to the heat action plan, we developed this heat action plan in 2013, the first version. It had 5 major components: the awareness and publicity about dangers of heat and how to protect, capacity building of the medical systems, reducing heat exposure and adaptive measures for the population, early warning system and interagency response plan, and monitoring the impact of heat action plan on health. And I'll show you quickly all these components. We did a lot of meetings, awareness with the traffic police, with NGOs, slum dwellers. Government also put a lot of hoardings, posters, and through newspaper awareness, because this was 2013-14 time where social media was not. Recently, we have been using more social media awareness. Now you see people also taking action in this form. You will see women going with umbrella, covering themselves up, etc. Second was building capacity of medical community. In medical curriculum, heat wave and heat stroke, etc. are taught. But when we found out in 2010, when real major heat wave came, the hospitals were struggling to treat heat wave cases. Part of the reason is that major hospitals, it is a vacation time. Teaching hospitals, half of the staff is on vacation. And other doctors maybe have forgotten how to treat heat emergencies because we don't see it so much. So we had refreshers training of half a day in many places where medical officers were trained. Then hospital readiness. Many hospitals in the city developed a cooling ward. Before the summer, one ward was prepared which will be used. So when emergency patients come, they don't fill up the emergency casualty departments. Then cooling ice packs, etc. And ice was prepared. Doctors and nurses were oriented, IV fluid. So all medical preparation, including in the urban health centers, ORS was provided because one of the way people die is dehydration. One of the mayors was very interested and he convinced many NGOs. He called, when he understood the plan, he convinced many NGOs, including religious, to open free water points, Pyau. About 700 to 1,000 places in Ahmedabad, people distribute free drinking water in summer. The other thing we could do, which was a major, in the minor thing, was the gardens were kept closed in the afternoon. They were open till 5 a.m. to 11 a.m. and then 5 p.m. to 9 p.m. After our pleading, the municipal authorities kept the gardens open so that people can take rest, because you need shade. The city becomes very hot, people are working, they should be able to, so cooling centers were developed. Then 2016 onward, each year we reviewed the plan, added new components. We added reflective roof or changing or coloring the roof so that the heat ingress in the building, because many people in the slums are working, women, especially women and children, are at home, schools are closed, people are in the house, but the house becomes like a oven because it is a tin roof house with no little ventilation. So this was then promoted to put reflective paint or to put something on the roof, including old gunny bags from the grain market, and then put water on the roof so as to cool the homes. The early warning system was developed by appointing a nodal officer of the health department to receive the IMD warnings, which they started producing in 2016, 5-day advance warnings. Before that, we had tied up with American University, Georgia Tech. They were providing the warnings and temperature forecast for Ahmedabad. And the nodal officer received the forecast and then communicated, depending upon the cutoffs, whether he would announce a red alert if it is going to be more than 45, orange alert if more than 43, and yellow alert. Later on, we realized zero error doesn't have much meaning because 41 to 43 degrees is quite normal in Ahmedabad. So we now focus only on orange and red alert days. And then in the heat action plan, what each department should do. Hospitals, labor department, water department, power department is all written. Everything doesn't happen. Some of the things do happen. For example, we had said that on red alert day, the water department must give additional water in the evening, which has not happened. But hospital preparedness, power supply should not be stopped, etc. School board gives a pamphlet to each child before the school breaks for the vacation. So all those many things happened. Finally, we every year after the summer is over, our team with the municipal corporation do an assessment of how many cases and deaths happened of heat stroke, how much implementation happened of the heat action plan. So this graph shows you the relative risk of mortality in relation to the daily maximum temperature in Ahmedabad before the heat action plan, which is the red line, and after the heat action plan. And we see clear decline in the relative risk of mortality, daily mortality, as the temperature goes above 44 degrees. So it seems that the plan has have some effect in the following years. Similarly, this is the reported heat stroke cases and deaths. 2010 is before the heat action plan and 2014 onwards is after the heat action plan. So the reported number of hospitalized cases, this is only from 5 major municipal hospitals, has also gone down. We also did some further statistical analysis and calculated that on an average about 1200 deaths were prevented after the heat action plan was implemented. And these are on various warnings. In the red warning days, which are only 21 days, we had 650 deaths prevented. So this is a more statistical analysis using the death registration data and warning data. This paper is also published later on with the help of IMD and Disaster Management Authority, because many places the threshold of mortality had not been calculated. So we were requested, we tried to do it in 100 cities. There are 2 ways to calculate thresholds as per the WHO, WMO guidance. One is if you have morbidity, mortality data on daily basis, which very few cities have. Otherwise, you use the 95th and 99th percentile temperature data to set up the cutoff. So this was done at our institute, and then National Disaster Management Authority has now taken it up, this heat action plan, to replicate in many cities of India. There are several cities now such and states. Over the last few years, National Disaster Management Authority is keeping meetings and workshops of the state disaster management authorities, and we are presenting this and other experiences of how to replicate this, and many cities have started now replicating. This was also now recognized as a disaster, because earlier heat wave was not recognized as a disaster. Only flood, cyclone, earthquake, etc. were recognized as disaster. And once it happened, that Mr. Harshvardhan noticed when he was the health minister, that after heat wave in Ahmedabad and Gujarat, there was a major heat wave within 2-3 weeks in UP and Bihar. So he also commented in one of the review meetings that such heat action plan should be replicated in many places. This work also got award in 2018. There is a JSW Times of India Earth Care Award on various categories. So urban category, we got this award with the municipal corporation. We have also developed other toolkits and things like that. The NDMA and the NCDC, Dr. Akash was there. They have also further now developed various guidance documents and things. The key lessons from Ahmedabad is first of all involve local city authorities or district administration with the health as well as the political leadership. What we did was each time we launched a heat action plan in the summer, we got the mayor and the commissioner to launch the plan. So they had fully understood and were behind this. Then engagement of all the stakeholders. The IMD is a national agency. They have the heat data. The municipal city government is the local health agency, which has the mortality and morbidity data. We also should involve the state government. So whatever is possible. We must use the local mortality and morbidity data to correlate with the temperature to determine the threshold and the effectiveness of the plan. Somehow, I don't know why India has a great reluctance to share daily mortality or even monthly mortality data of any city. No city I know puts it up in the newspaper next day. We know what is the temperature yesterday, but we don't know how many people died in the city. I don't know why there is so much of secrecy about mortality. So facilitation by local, national and international universities and experts. What happens is in the city government, people are very busy doing day-to-day work. They don't have much time and capacity for analytical work or reflective work, looking at international experiences, etc. So partnering, and most major cities have IITs, IIMs, other universities, but somehow the linkage between the city government and universities is very, very weak. That we cultivated and sort of nurtured, and that led to our, in some sense, success of our heat action plan. We have to learn and adapt from whatever is done in other countries. We learned from Chicago, we learned from California, we learned from Europe, WHO guidance, etc., and implemented it and modified and implemented it, and measure the process of implementation, whether things planned are happening or not, and what is the impact on mortality and morbidity. Then you see whether some things are working, not working, etc. These are some of the references. I can share the slide set. You can then see later on. Even process is documented. There are papers published. I just want to end by showing you this graphic, which I don't know whether Professor Dr. Akash showed. This is the Ipcc predictions with various modeling. And the redder the area, the more hotter it will become. And we are currently at B1, which is the left-hand side top corner, which is 2011 to 2013 time period. We will move towards the right-hand side as we reach 2080 and 2099, which is the last column. Of course, everything will become hot in any scenario, whatever. The top scenario is the best if we reduce the carbon emission the most. The middle one is the middle projection, and the bottom one is business as usual. We keep on no reduction in carbon. You see, what we are facing now as heat waves is just the beginning of the next 80-year journey, which is still to unfold on ourselves. And if you see the bottom graphic line, it is dark red is 4 degrees centigrade increase in temperature. And this is average temperature of the whole world. So the hotter places will become 10-15 degrees hotter in summer. You may have remembered there was a news in March this year that the North and South Pole, the recorded temperatures were 40 degrees above what is normally recorded at that place, which I also first didn't understand what it is. But when I looked at it in detail, it was really 40 degrees more. They're already recording. If you see the darker areas are at the top. So what I'm trying to say is that unless we wake up and take action, we will be really in very hot soup in many health and nutrition issues. Thank you very much. These are our partners. University of Washington, Mount Sinai Hospital, 2 very good physicians helped us. The center, the main thing was done by the Municipal Corporation of Gujarat, and the IMD and the emergencies ambulance service also helped in this whole effort. Thank you.
Thank you very much, Dr. Mavlankar. That was an extensive, exhaustive, very informative lecture, which showed how by putting your heart and soul into a job, you can manage to get several kinds of people to pull along with you, and how public health facts can be brought out. There is no class mathematics, but simple day-to-day available data can be put to use to bring out public health messages. And the advantage in this is that it is open to all, it is understandable to all. And the fact that so many people in Ahmedabad are using umbrellas and covering their faces and noses, and there is adequate drinking water, that is in fact the kind of public health intervention that saves lives across the world. Thank you very, very much for that. I thoroughly enjoyed the lecture. And now the question 10 minutes are open. I am going to read the first chat message. Very informative lecture, an observation and a question. Since solution to climate change and food and nutrition security are closely related, have there been policy decisions or programs implemented which address both these issues together? Thanks.
Yeah, I must say the health part I know, and Dr. Akash explained. The nutrition part I don't know, and I don't work in that area, so I'll not be able to see. But at least I was scared to read the news in this year's March, April, I think it was March time, that the wheat production is going to decrease by 20-30% in some areas of India because of early summer, because wheat needs certain time to mature. And we had very early March was becoming very hot. And if that is started happening, it is really a worrisome news that if food production starts going down. I don't know the other issue, which I don't know whether it is pertinent. I was also very worried, and I think we were writing or wrote something. When food prices are going up substantially, what happens to the nutrition security? I don't know if food prices are related to the food production decrease or what other things are there. But we also saw very high inflation in food prices. Now that also will have a lot of effect on nutrition related things.
Thank you. That really is the answer. Yes, they are all interrelated. And it is not only the early onset of summer, but also the delay in monsoon in some parts of India, which interfered with sowing. So you had a wheat crisis because of early heat. You are having a rice sown area being lower, mainly because of delayed monsoon. Onset was okay, but there was a tremendous delay. It is, I'm sure that kind of questions are going to be addressed in the next two presentations. Any more questions? Dr. Nair, very informative. Thanks. What are the measures that can reduce food-related carbon footprints that can be practiced by the general public?
Food-related carbon footprint.
Yes.
I'm not an expert, so I don't want to answer that. Maybe in the next presentation, people can.
Okay, Dr. Nair, wait. The next, not the next, but the next to next, I will show you some data on that.
Yeah. As a lay person, I know that as we become richer and richer as a country, we are throwing away more and more food. And that may have some impact on the, because the water and things required for producing the food, the rich people are buying and throwing away or not using. So those kinds of things may be there, but I'm not an expert to answer this.
If there are no more questions, can I thank Dr. Maulankar from really, really bottom of my heart. I enjoyed your presentation immensely. And I'm sure I'm only saying what the others feel. Thank you so very much, Dr. Maulankar.
Thank you.
I am going to ask you a question. Usually we share the slides. Will you have any problem if we put it in our website?
No, you can put it. No problem. Yeah.
Thank you so very much. Because I'm sure many people would love to see and learn from the fact, very simple bar diagrams, line graphs,
Yeah.
using simple things that are available can produce excellent results if you know what to do. Christ, the
My
problem is,
only key message is this doesn't have any artificial intelligence, any machine learning, no computer. This is a 7th or 10th standard mathematics we are applying.
yes,
So please don't wait for artificial intelligence. Please use human intelligence first. Use the local available data. And this is what the politicians will understand. Because if you show that, okay, with this temperature, so many people died. Now that even a lay politician or the mayor of the city understands, commissioner understands. You say we build a mathematical model in the air, in the computer, and it is going. So they said, I don't understand what is to be done. So in that sense, I think the simplicity has helped. My only personal, what should I say, remorse is that no other city is doing it. We have been doing it for 10 years. We told Delhi people to do it. We told Nagpur, we helped Nagpur to do it. They did it for some time, but nobody is owning up. No university, nobody. And government now, especially with COVID data, has become even more cagey of mortality records. This was even before COVID. Still not many cities were looking at their daily, because daily death is like a thermometer. It shows you something is wrong in your body. It doesn't diagnose what is wrong. But if you say that daily mortality should have been 60 and it is 80, I should, as a health officer, be worried, or as a public health person. But if it is 60 or 65, I'm okay. So that even basic, which Europe did 300 years ago. If you see the bills of mortality of London, some of you may know, where weekly, daily, weekly totals of mortality. We are not even doing that kind of public health. So thank you very much. I don't want
thank
to
you.
belabor
And
too much.
can I tell you one thing?
Yes, madam.
There is a tipping point for everything. For a long time, nobody seemed to care. But you are building a groundswell. And at some time point, the tipping point will come. And then suddenly you will feel, oh, it has happened. We saw it in iodine deficiency disorders in public health. Till 2005, we were desperately feeling unhappy that the cause is getting lost.
Yeah.
2007, somebody gathered the political and administrative will to make it mandatory. 5 years, we are near universal. So don't you worry, good work will get all its excellent public health results to not only Indians, but perhaps the world citizens too. Thank you.
Sure. Thank you, madam. Thank you very much.
May I now request Dr. Lakshmaya to make his presentation on what has been troubling others, nutritional problems and climate change. What action are we to take? Dr. Lakshmaya.
Thank you, madam. Good afternoon, everyone. I'm just, may I share my slides?
Yes.
Is it visible, my slides?
Yes, your slides are fine.
Okay. Moving? Are the slides are moving?
Yes, slides are moving.
Okay, so Thank you very much, madam, for giving this opportunity to say about climate change and its impact on nutrition and options for action. So, because this is may not be a new subject for everyone, everybody knows that the climate impact how adversely affect our nutrition. So I don't want to take much time on climate because several previous speakers they explained brilliantly what are the effects of climate change and how many domains it affects and how the life is measurable with the increase of temperature and other things. And thank you, Dr. Molankar, and the excellent presentation. So climate change and food and nutrition security. First effect on food and nutrition security. The food and most of the nutrition security, even madam will going to address in many ways. And so I am focusing on nutrition security and its effect. So this is as previously several even audience also raised that there will be some overlap will be there. So that because some overlap we cannot avoid, but we'll try to focus on what we have to discuss. So here the steps, the nutrition ultimately how it affects the food security and causes, and that will lead to malnutrition and climate change and food security, climate change and food security future and improving the food security. So these are the major issues. The food security and right to food and food security defines this everybody aware that as a FAO definition. So the right to food is a universal and international covenant on economic and social cultural rights. This was done in 2004, and the related concept of food entitlement was identified by 1998. The Nobel laureate Amartya Sen also stressed the need of food distribution and especially strengthening of PDS and other things. So the causes of food insecurity, they have given major four grades: the uncertainty regarding ability to obtain food, and compromising the on food quality and quantity, and reducing the food quantity and skipping meals, and no food for a day to eat. So this is divided into three categories of food insecurity. One last one is the food insecurity, severe food insecurity. So what is that mean is a person is food insecure when they lack a regular access to enough safe and nutritious food for normal growth, development, and an active and healthy life. So this may be due to unavailability of food or lack of resources to food or to obtain or purchase. So the price, even previously also we discussed that price automatically, if availability is not there, if production of food is not there, the price automatically increase. So availability and accessibility will differ. So food insecurity can be experienced at different levels of severity as above. And FAO security using the food insecurity experience scale shown above. And this food insecurity, because we have also done 2-3 surveys on food insecurity scale fees in Madhya Pradesh and even on some of the states. This scale was also modified to Indian conditions. Please, mute others, please. So it is creating a lot of disturbance. Please, except speaker, all others, please mute your. The causes of food insecurity. This is a short-term consequences and long-term consequences, and you can see this especially affect on maternal and child undernutrition. So the primary cause would be inadequate dietary intake. So then it leads to disease and immediate causes and household food security, insecurity, inadequate care, unhealthy household environment and lack of health services. Underlying causes, income poverty, employment, self-employment, all this will be definitely reduced, and the lack of capital and financial and human, physical, social, natural effects also there, socio-economic and political context also will cause the food insecurity. So the climate change, what are the climate change and fundamental requirements for health? These are already spoke. Some of the clean air is required, safe drinking water, sufficient food, secure shelter, and reasonable income. All these things are important for living a healthy life. And so the extremes and violent weather events and the resource of disease organisms vector and broadening altitudinal distribution of vectors, especially even Dr. Srivastava already explained the vector conditions and quality of air, food, and water, and the stability of the ecosystem. This is also very important ecosystem, stability of ecosystem for production of for diversity and food production and all the other things. So here, nutritional well-being for all, how these four important domains. One is the food and nutrition security, then care for the vulnerable, and health for all, and safe environment. So all these four parameters directly, indirectly affect on climate change. So the fundamental definition, I need not repeat this, what is health, you know everyone, and what is nutrition and what is malnutrition, both including undernutrition and overnutrition. And nutrition is a fundamental pillar of human life, health and development across the entire lifespan. So from the earliest stages of fetal development to old age, all these stages will affect because of the nutrition or undernutrition. So proper food and good nutrition are essential for survival, physical growth, mental development, performance, productivity, health, and well-being. And nutrition is an essential for fundamental human and national development. Even World Bank and IMF and all they stated that nutrition is for center for any country, development of any country. So the why we are worried about nutrition, because the undernutrition is directly or indirectly causing 60% of major causes of under 5-year children deaths. So then if you improve the nutrition status of these children, we can save more than 60% of child mortality and neonatal mortality. And this here for regarding India, this paper was published. I am also one of the author in this paper, and the subnational mapping of under 5 and neonatal mortality trends in India, global disease burden, under this banner, this was published. So these are all who are vulnerable for nutrition: infants and young children, adolescent girls, pregnant lactating women, elderly people, then socioeconomically deprived groups. So these people already in deprived things or some undernourished things. If the climate change also influence further deterioration of these condition and this triple burden of disease we are already facing, and undernutrition, micronutrient malnutrition, and overnutrition. Some of the I'm going to talk about much on overnutrition, climate change, but undernutrition and micronutrient deficiencies will definitely affect the this climate change, and these are the triple burden of diseases, and this is a global scenario. We are already 2 billion people are suffering from micronutrient deficiencies, one or the other, and 55 million children are stunted. Out of this 55 million, 1/3 children, we are India alone contributing, and other problems are there. If you see the burden of undernutrition in India, you can malnutrition, you can see stunted children, 746 million, and 72 diabetes, and 166 overweight. 166 million people are suffering from either overweight or obesity, and majorly micronutrient deficiency and anemia. So the chronic malnutrition, the best indicator of the quality of life, is a sign of structural problem. This is the structural problem. You can see easily understand stunting and how overweight, obesity, and this is the recent statistics. The NFHS 5 shows that this is the NHS 5, NHS 15, NHS 18 recent data shows that. So there is a small reduction, but it is not a substantial reduction. Even NNMB also shows that the undernutrition is very high, especially tribal population, rural population, compared to urban population. Even urban population also, the undernutrition is very high when compared with the developing and developed countries. And so this paper was also recently published, how the food intake affect the undernutrition failure. And this is association between anthropometric based and food based nutrition failure among children in India. So this clearly shows that there is we have compared with the below RDA and the above RDA intake and stunting and correlated with stunting and wasting. Wherever the food intake is less or cereal or millet intake is less and energy intake is less, so the undernutrition failure was noticed. And if you come to the macronutrients is essential for several. I'm not going to explain all these things. Everybody aware that the micronutrients is affect several ways. That in especially 13 vitamins and 14 minerals that are only needed in a small amount but are essential for human health. So these micronutrient deficiencies affect on fetal child health, cognitive development, resistance to infection. So the public health implications of micronutrient deficiencies are potentially huge and significant for its prevention and control of these diseases. So these are all micronutrient deficiencies. Micronutrient deficiencies and the ugly face of hidden hunger is the iron deficiency, folic acid deficiency, vitamin E deficiency, iodine deficiency, and zinc deficiency. And iodine deficiency is we have several intervention programs, and this is only the one successful public health program for iodine deficiency disorders. So we have published on the vitamin E deficiency and in India. So this clearly shows that there is a change in there is an improvement in the vitamin E levels, and there is a decrease in the ocular signs, but still some deficiency. The subclinical deficiency of vitamin E is still persistent, and iron deficiency is still public health problem. And recently we have also conducted B12 deficiency, mapping of B12 deficiency in India. And this B12 also is almost 25% of our population is suffering from B12 deficiency in different age groups and gender. And of course, the vitamin D deficiency also there. And this another paper we published, the different micronutrient deficiencies in India. And ultimately, so what are the determinants? So we have come to this very conclusive things is one of the important parameters are climate changes and agroclimatic changes, and this is other pathological conditions also will change because of the temperature changes, climate changes, and all these things. The diarrheal infection, malaria, many zoonotic diseases also affect. Ultimately, the nutrition status will affect. Because of the food production, land ownership, type of land, rainfall. Maybe Dr. Prema Chandran, Ramchandran Madam may be explaining further all this in under food security. But these are the crucial things will affect the thing. So as you know, NNMB, the NNMB surveys estimated consumption levels of all the food and nutrient intakes, and why I'm showing is already the food intake is very less and nutrient intake is very less compared to when RDA or EAR. You can see this is 1 to 3 year children. The food intake, if you see, except cereals and roots and tubers, some other vegetables, but other things, pulses, green leaf vegetables, milk and product, fats and oils. So all these things are the consumption is very, very grossly inadequate. So if add climate changes, and this may go further deprivation and all these age groups. So that is my point and concern. And this is if you see the converted those foods into nutrients, this is the nutrient composition, nutrient intake position. Except protein, some extent calories and thiamine. Others are you can see vitamin A is very grossly deficient, iron, calcium, and most of the minerals and vitamins also. In almost all, even adolescents, adults, then pregnant women, lactating women. So this just to check what is the existing scenario, and if this adds to climate change, how it will affect us. So that's what my point to show. And this average intake of foodstuffs, even over a period of time, also there is a decrease in cereals and pulses. There is no change. Little improvement in GLV and other vegetables. There is no change. And you can see roots and tubers, there is so milk and meat, there is no change. Fats and oils almost same. And sugar and jagger is even still decreasing. It is a good also. So these are the existing scenario. So what is the climate change adding to the problem of existing food security? So the food security is already a significant challenge, and all else equal, our climate change is likely to worsen global food security. So there are clear steps that can be taken to help mitigate the anticipated challenges of food security attributable to climate change. So some of the studies we have conducted, based on those NIN studies, I want to give some results what drought and this flood effect on this nutrition status. So here the drought in 2001, 2003, 2009, 10, 11, these all these years also very severe drought we experienced. So this natural calamities like floods and famines, cyclones, earthquakes, disasters especially, the basic reason is the reduction of agricultural production, agro-based industrial output, rural employment is reduced, purchasing power also reduced, household food and insecurity and migration, lack of labor migration will be there because there is no opportunity for labor in those same drought areas, especially in the routine drought, especially in Rajasthan, Gujarat, some of the areas. And large-scale displacement and death of cattle and human beings also occur, and prevalence of undernutrition and epidemic disease and mortality also. These things will be increased, and then agriculture area will be decreased. So drought impact on nutrition, the NNMB and NNN studies we have done in 2003 and 2009 and 10. So during the earlier episodes of drought, average calorie consumption in affected area of Andhra Pradesh, Bihar and Maharashtra was observed to be ranging from 1100 to 1400 kilocalories per day. So there is a drastically decrease in the consumption of calories, a level barely sufficient to meet the basic needs. So this was observed in 2003, and percent of families consumed less than 5 years kilocalorie per capita per day. This is what we have definition. As per the definition, it is a starvation diet. So in Andhra Pradesh, Bihar and Maharashtra, this is the starvation status of in these states. The Andhra Pradesh, it was very high that time. And then next Bihar, then Maharashtra. Maharashtra is better than these states during drought time, I'm telling. So this is, we surveyed in drought affected areas only. So that's what I'm trying to tell. The prevalence of clinical signs of nutritional deficiency signs, even you can say the clinical signs is marasmus is very high that time. And kwashiorkor is also high, conjunctival cirrhosis, bitter spots. In Bihar, the marasmus is very high. Maharashtra also it is very high. Conjunctival disease is very high in Maharashtra. So these are the effects observed during drought, and the continuous drought was there during that time. So the state Rajasthan experienced drought conditions in the beginning of new millennium continuously for 2-3 years. So at the request of Ministry of Agriculture, Government of India, ICMR, the present survey was carried out. So these are the pictures in Rajasthan. You can see because of drought, there is no water, no greenery, and this is the condition of animals. You can see lot of cattle is first severely affected cattle. Then these are the cattle in the cattle sheds. Even government is providing some fodder and other thing, but in spite of that, so the situation is very worst. The carcasses here and there, they thrown away carcasses. We physically visited all these areas for just to assess the drought condition, especially on nutrition status of people and what is their diet intake and other things. So these are the scenarios was seen in Rajasthan. And there is a very severe scarcity of water, even drinking water. And you can see the drinking water is also where scarcity is very high. So they are saving even the bathing water also to use some other purposes. So here, this is a food insecurity. And these are the average household food consumption of foodstuffs. You can see. So we compared with the drought and during non-drought areas. So the drought areas, the consumption levels are less in most of the states, but here in Rajasthan also compared to RDA, both are less, but still drought worsens the conditions. So here also the average household intake of nutrients, if you see, So here the drought and you can see this is a normal condition. This is during a drought conditions, and this kind of children we seen very frequently in those villages. And this was a paper was published. You can say diet and nutrition during drought in Western Rajasthan, and here so the we have used the insecurity scale perception of head of the household, sufficient and insufficient, cereals and millets 84% and 15% sufficient. So because of the programs are existing, PDS is well worked there. So the cereal millets not much, but you can see pulses. The insufficiency is very high. Vegetables insufficiency is very high, and milk products also high. So fats and oils also very high. So the insufficiency except cereals and other things are very insufficient, and this is the condition. And the in this the coping strategies. What are the coping strategies they adopted is use food stocks and money and savings. This is 39%, and purchase low cost food items in that during drought 31%, and borrow cash and food from neighbors 51%, and gather food from surrounding areas and seek additional employment, then seek or obtain government assistance and reduce food consumption. This is a very pathetic situation because these people are already consuming less, and during that they further reduced their intake levels. They skip the meal sometimes. So these are the scoping strategies they adopted during drought. This is also during drought and NPI Rajasthan non-drought. We compared with the both things we can see here. And this is even BMI also. There is a drought, and during drought the BMI levels also changed, increased this. So the comments are significantly high proportion of households were having food insecurity during drought among especially scheduled caste and scheduled tribes. The impact of lack of food security was reflected as a higher incidence of undernutrition. However, availability of subsidized food grains through PDS, accessibility purchase of food through provision of employment under HGRY might have averted the population from severe nutritional stress like deaths and other things. There is a need to develop a long-term strategy for management of recurrent drought conditions through an integrated policy of water and land management linked to employment, and strengthening of short-term approaches include cash programs of employment, supply of food, fodder, drinking water, and provision of health and veterinary care to meet emergencies is also equally important. As these are the recommendations we have done, and we have shared with this ministry and the government. So another issue, health and nutrition during this floods, tsunami. Everybody aware that 2006 there was a great tsunami. So the deaths and missing subjects in Nicobar districts. This was so the government is requested us to come and assess the situation, flood situation, how coping strategies and how relief measures are working there. So we went as a team in from NIN to Andaman Nicobar, and we were there more than a month there. And we visited several islands there, and so we assessed the situation. So these are some of the relief measures include. These are the things they have given by the government and NGOs. So all these things, and these are the they also provided some 1 lakh rupees for those who are dead, and 10,000 for lost property. And these are the measures the government has taken. And the government has established a centralized kitchens and the camps, relief camps, and under the relief camps, the food distributed. Food was served because in the 3 times food was served in those camps, and we have also done some their anthropometric measurements there, and we have assessed their how much diet they are consuming through these central kitchens, and what is their actual requirement, whether they are meeting or not, and what are the nutrition problems they face during this flood situation. Because everybody knows that it's a very devastating tsunami in that year. Then we have also done some blood sample collection, and especially we analyzed the vitamin A and HB. So these are the intake of protective foods such as GLV and other vegetables MFP was very low. But these are our findings, and this was reflected in low intake of micronutrients such as iron, calcium, vitamin A, riboflavin, niacin, vitamin C, folic acid, and low serum vitamin A. So except calories and protein, so other things are very less. And the Nicobaris are nutritionally better off compared to the settlers. We also compared their present status with other settlers, those who are coming from Madras and Tamil Nadu and other states. So the nutrition status of settlers was closer to the rural mainlanders. The prevalence of various morbidities among the population studies was relatively low. No epidemic was reported in these areas because of better preparedness. So the impact relief measure, the timely and efficient implementation of relief measures by the Andaman Nicobar administration, along with national and international NGOs, significantly contributed in the prevention of deleterious effects of floods generally encountered and the loss of property. So improvement of micronutrient status of the community, especially preschool children, by increasing the coverage of IFA and massive dose of vitamin A, and supplementation of micronutrient fortified biscuits to preschool children and under ICDS initiated by UNICEF may be strengthened and extended to all the areas. These were the recommendations we have given. And the community to be educated to grow and consumption of protective foods and change of lifestyle through nutrition education among Nicobaris due to overweight and obesity, especially in adults and adolescents. So after receiving our recommendations by the Andaman Nicobar administration, I have started the IFA tablet distribution and coverage of massive dose of vitamin A by campaign approach. And this indicates the promptness of the administration. They acted very swiftly, and they have implemented our investigation. So the climate change, the preparedness, the pre-disaster and the response and the post-disaster recovery and mitigation, these cycle of approach is very, very important to avoid these very sensitive. Nutrition is a very sensitive indicator. So if 1 week the nutrition consumption or food consumption is decreased, definitely the effect will be seen as a clinical or subclinical aspects. So the climate sensitive elements to the food system is very essential. So these are the components we have to encourage, and as previous speakers already said that NDMA is working, Ministry of Defense. This is the disaster cycle. We have to prepare. Preparedness is very, very important, and so these are the responses and preparedness, response, recovery, and mitigation. So then only we can save the life, and development of DRR, the disaster risk reduction plan, is very important. And in that plan, the awareness, creation of awareness is very important. Training and capacity building of this different stakeholders is very important. This what this is already this NPCCH. They are already doing NCDC, the Ministry of Health. So ongoing intervention we have to strengthen. Monitoring, evaluation is very important, and screening is very important. And strengthening of existing facilities is very important. Then only we can avoid this climate change impact, negative impacts of climate change. And so steps to improve future food security. So improve the governance and leadership, and secure the food entitlement, and pursue, encourage technological breakthrough, water quantity, quality of the water. Also, we have to see more investment in research for sustainable agriculture. This area is very important. As even Dr. Srivastava also said that the research on climate change is very important. I'm happy that ICMR has taken that initiative, and steps to improve further food security, address food demand and supply. Population growth not fixed can be reduced by reducing the global inequality. Limit meat consumption to 90 grams. Of course, in India, the meat average consumption is only 34 grams per day, but in some other countries it is very high. So the improve the food production models and pursue the climate change. And this is very important. Last one. Unfortunately, we don't have any nutrition surveillance system. So we have to nutrition surveillance system, establishment of a nutrition surveillance system is very, very important to monitor the climate change. Otherwise, also we have to see the monitoring of food and nutrient consumption for different various physiological and gender population is very important because nutrition and health, you all agree that nutrition and health we cannot separate. Nutrition leads to health and health leads to nutrition, the digestion, absorption, availability, and all those things. So in drought conditions, the initiatives taken by the government is very important, and the food for work programs, because the purchasing power of the population will be automatically reduced during drought. So the purchasing power we have to increase as a political will or as even agriculture initiatives and health initiatives. So thank you for giving this opportunity.
Thank you very much, Dr. Lakshmaya, for that exhaustive presentation. You already have a question in the chat box. Dr. Nair wants to know, nutrients are directly linked to climate change, such as vitamin D, need to be highlighted, especially in tropical countries. What are your priority nutrients that are negatively impacted due to climate change, and what are the steps to address them? Thanks for a very good overview.
Thank you, Dr. Nair. Because the climate change, because I am not discussed much about on nutrition composition. The nutrition composition itself will change. That even Nair knows that because the climate change may especially minerals and vitamin content of the crops also will be changed. So that maybe Madam may be presenting in her presentation. So that is the major things. But here the vitamin D especially is a sun vitamin, because climate change, sun is there, but the sun only not important. And otherwise even other micronutrients also very important. So that way we can.
He has one more question. Do we have a plan to integrate diet and nutrition surveys with IMD database to assess the impact of climate change?
No, exactly we are not doing that. But however, we are this survey itself, the dietary mapping in India, we have planned to conduct different agroclimatic regions. Based on agroclimatic regions, we want to collect the data, but we will see the agroclimatic means all, even this rainfall and everything will be considered. So we will say in the analysis itself, we can say where which agroclimatic region people they consume better and other agroclimatic people they consume less. So those kind of analysis we can do. So we are taking in every state and 6 agroclimatic regions we are going to cover and see the agroclimatic regions effect.
The last question will be Mr. Gautam Sen.
Dr. Lakshmaya, you have made a very important point about developing a nutritional surveillance system. How would you like the system to be managed?
Yes, sir. Here, actually, this was thought of not now. It is 2 decades back only we thought of, and it was included in the even 5-year plans also to establish nutrition surveillance system. But unfortunately, this is not taking place much important, because we tried this establishing nutrition surveillance system in 5 states, and as a model in 6 states. In each region, one state we have selected, and we have done 3 years nutrition surveillance model. But this may require a lot of financial allocations, and we take up a by central government, and then it give very good results, because in the monitoring system we used to collect all the nutrition indicators and even food production, including food production and nutritional deficiencies. And we have also tried to develop this by real-time basis, because we have distributed more than 1,000 tabs to the hospital. We have taken, sorry, we have taken this system. We have taken the.
इतने वाइस यूज हो गई 5 वाइस
Will
Hello.
the participants please mute?
Please mute, please. Otherwise, it is disturbing. Actually, it is a very good question, because we have taken the existing system, health and ICDS, on the based on health and ICDS system. We have used this system for Anganwadi workers as well as ASHA workers to monitor the health and nutrition status by the way of nutrition surveillance system. And we have completed 3 years, and we are now writing a report, final report. And this is a pilot study we have done. And the preliminary observation, what we have seen is it is giving a very good impact the surveillance system, because a lot of warning signs also we can see. And this in nutrition surveillance system is also working on a AAA approach. It is a assessment, analysis, and action immediately. So this is the AAA approach we have recommending to scale up this system. We will see how it will be scaled up, and how the government is taken up seriously. Thank you.
Dr. Maulankar has a comment. I think it is extremely valid. Agroclimatic data, food price data, and nutrition data should be integrated. Definitely at the state level, perhaps even below up to the district level. We have to make a beginning here. I'm sure Dr. Lakshmaya agrees, don't you?
Yes, madam. Yes, madam. We are trying, but it may not be possible district level, but regional level. Within the state, we are some 6 regions we are selecting, so that we can try, and we will develop the models.
Thank you so very much. Thank you, Dr. Lakshmaya, for that exhaustive presentation.
Thank you. Madam.
Will you stop sharing so
Yeah.
that
Thank you all. Thank you, madam.
Thank you very much. We are now coming to the last presentation. This is on climate change and food security. As has been stated by everybody, there are interlinkages, and especially the linkages between food security and nutrition are like linkages that we have between Nutrition Foundation of India and National Institute of Nutrition. We are organically connected. We learn a lot from each other, and we help each other in times of need. Food security, the problem is that there has been changing concepts and definitions, and depending on when it is that we were in the in our educational curriculum, we have our definitions of food security. The fact that the world has moved several steps ahead is something that many people do not take into account. We will also briefly talk about climate change, causes and dimensions, mainly because there is a belief that it is all due to energy, construction, and carbon dioxide emission. There seems to be very little awareness that improvement in agricultural practices and waste reduction can go a long way in reducing greenhouse gas emissions. This greenhouse gas is essentially methane. I will briefly touch upon impact of climate change on food production and food security, and finally talk about the action plan to address adverse impact of climate change on food security.
Yeah. అది ఫోన్ చేశాను తమ్ముడు నాకు లెక్చర్
This is what we would like everybody to eat, but very few people do eat it. Evolution of the concept of food security is something that I would spend a minute on. We all know food is an important determinant of nutrition and health status, and therefore food security of the population, especially vulnerable groups, have received priority attention both globally and in India. In 1950s and 60s, food security was defined as countries consuming sufficient amount of protein and energy, that is essentially food quantity. In the 1980s, the importance of micronutrients for balanced and nutrition diet, that is food quality, was recognized. Problems of absorption of nutrients, example in children with diarrhea, or excessive loss of nutrients, example children with respiratory infections, which can adversely affect food utilization even when adequate amounts are consumed, were recognized only in late 1980s and early 1990s. Therefore, the third dimension, that is food utilization, became increasingly prominent in the food security discussion in the 1990s. The World Food Summit in 1996 redefined food security. Dr. Lakshmaya has already defined it, so I won't read it again. But all that I will state is the 4 pillars on which food security rests is availability, that is land, water, labor, biodiversity, technologies, credit, and subsidies form one pillar. Access, which depends on purchasing power, employment, social safety nets, and social insurances form the second one. Utilization, namely balanced diet, food safety, sanitation, and processing, is an important pillar, while the stability, which is whether there is availability, markets, information, infrastructure, transport services, and intermediaries, are critical. And stability for 1, 2, and 3rd pillar are essential for food security. If people are not food secure, they are food insecure. Food insecurity can be acute or chronic. Acute food insecurity is usually associated with natural and man-made disasters. Management of acute food insecurity is an important component of disaster management, as has been stated by the earlier speakers, whether they talk about tsunami or cyclone or floods. Acute food insecurity management is part and parcel of disaster management. If the disaster management is effective and the duration of food insecurity is short, the impact of acute food insecurity on health and nutritional status can be limited and transient. But disasters do have an adverse long-term impact on livelihood, earning capacity. If post-disaster rehabilitation programs are not energetically implemented, families can slip into poverty and chronic food insecurity. There is a severe, prolonged acute food insecurity in terms of famine. Thank God, in India, we haven't witnessed it since early 40s. But even now, there are nations and sub-regions in nations in sub-Saharan Africa which do witness severe and famine conditions. Acute food insecurity results in acute weight loss and wasting. famine can be life-threatening and energetic steps are needed to combat it. In contrast, chronic food insecurity is, we don't even know when it began and we can hardly say when it ended. It can be transient and short-term. That is usually witnessed in many parts of sub-Saharan Africa as pre-harvest season and during drought. It can be long-term and persistent, such as seen in poverty and marginalized population groups. Chronic food insecurity leads to inadequate food consumption, and persistent chronic food insecurity and low food consumption results in undernutrition and micronutrient deficiency. I hope this answers the questions on the linkage between food insecurity and undernutrition. FAO has historically used some indicators for monitoring food insecurity, and they also have changed over time. Initially, consumption of calories less than 2100 a day was used as a parameter by FAO to define global, regional, and national levels of food insecurity. If this criteria was used, India was always labeled as hungry and food insecure. But there has been a change in the last decade because under and overnutrition have now been recognized as problems across the globe. And in fact, in many parts of the globe, overnutrition rates are much more than undernutrition rates. Recognizing that all people are not given the genetic and environmental mandate to have a standard height and weight, we now calculate PUO depending upon each country's minimum dietary energy requirement. Roughly, minimum dietary energy requirement is the energy requirement, average energy requirement minus 2 ST. It's a very rough and ready way of calculating. There are sophisticated methods which will be used. Adjustment to the series in each country is made as better information on dietary intake and nutritional status are available. FAO compiles these reports, and currently these are called yearly state of food security and nutrition reports. But FAO also, and globally every country also, recognizes that food insecurity is not all energy. So they are now trying to assess through interviews of people involved in different situations, what do they call as their food insecurity experience scale. It takes into account their average earlier consumption, the current consumption level, like what Dr. Lakshmaya had told, and also coping strategies through which they try to ensure that at least the most vulnerable segments do get the minimum essential requirement. Of all the parameters widely used to assess chronic food insecurity, anthropometric indices had been the most objective and most has been in vogue for the longest period. Especially stunting, chronic underweight, and wasting in under 5 children had been widely used. These have their own problems, and we will Dr. Lakshmaya to some extent showed how this varies in different situations of nutrition. We'll first now look, like I defined what is food insecurity and food security. We will now briefly review what is climate change, its causes and dimensions. One thing for sure, over time, across years, there has been across all months of the year, a rise in average temperature. Global warming, therefore, is a reality. It remained essentially stationary between 1850 and 1950, and thereafter, over the last 70 years, there has been a steep increase. The increase from natural drivers has remained stationary. The increase from human drivers has galloped. The most important cause of rise in global temperature is fossil fuel conversion into carbon dioxide and carbon dioxide emission. 10 countries who were the major contributors of greenhouse gas emission contribute to nearly 70% of all emissions. These are mostly developed countries, and the developing countries always tell they have a greater responsibility to reduce their own greenhouse gas emission and also to assist the developing countries in their attempts to limit greenhouse gas emissions. But there are nuances even there. Between 1870 and 2019, India's contribution was a mean of about 4% of total greenhouse gas emissions. But now start looking. In the last few years, India is contributing more and more to greenhouse gas emission because it is trying to catch up with improvement in quality of life of its citizens. We also would like to point out that both India and China are now the first and the third greenhouse gas emitters. But in terms of per capita emission, United States and Europe stand taller, and even Russia is higher as compared to China and India. So we need to allow populous countries to concentrate to some extent on their developmental dimension. And there is a desperate need for developed countries with lower population density to invest not only on reduction in their own emissions, but also economically and technologically assist the other countries in reducing their emissions. I would also like you to have a look at this. Greenhouse gas emissions are not really totally because of a carbon burning. Agreed that it is a major one, but forestry, agriculture, wastewater management, they also contribute about a fourth. And if you look at manure management, crop residue management, and one of the most important things, emission from soil and enteric fermentation from industrially grown cattle for meat, they do contribute substantial proportion of greenhouse gas emissions. So improvement in agricultural technologies, better waste management, and use of appropriate technology for forestry and animal husbandry can substantially decrease greenhouse gas emissions without affecting food production in developing countries. However, for industrialized countries, industrial level animal husbandry for dairy and meat production will have to be substantially reduced. There is neither the health benefit nor is there any other benefit for consuming so much of dairy products and meat. And this is what is now being increasingly vocalized as the eat right movement in the developed countries. While talking about this, we also need to look where does climate change has the maximum impact on food insecurity. Nowhere else excepting the most populous continent of the world, Asia, both China and India are very vulnerable to adverse impact of climate change. I will skip this slide because Dr. Lakshmaya has already shown. I would like to show you the impact of climate change on various agroclimatic zones. The north, central, and northwest drought-prone regions are likely to become much more adversely affected by heat waves and droughts. The flood-prone Indo-Gangetic and Brahmaputra Valley will be more flood-prone because the higher reaches, in addition to monsoon and its vagaries, the higher reaches glaciers are melting and they will also cause flooding. Cyclones, we know about it. We always had it in the Bay of Bengal, but currently cyclones affect the Arabian Sea too. Sea level rise and salinity are also going to be major problem across the long coastal line in India. We will talk about the acute food insecurity associated with disaster. Essentially, it is really a 3-time point intervention. On one side, we have to assess the risk. How do we mitigate and prevent it? Most important of all, how do we build up an early warning system, preparedness for evacuation to minimize the losses, not only of human life, but also of cattle wealth? We have to strengthen the search and rescue operation, re-establish logistic route, and provide all necessary survival and food security during acute disaster. This has to be followed up by re-establishment of developmental activities, reconstruction, economic, social recovery, restoration of infrastructural facilities, so that this acute disaster does not become a chronic food insecurity. Therefore, what about India's track record? Essentially, if we look at it in acute food insecurity associated disaster, it is mostly natural in India. Frequency and severity are increasing, we have no doubt about it. But because of the tradition of having so many disasters across the year in different parts of India, India has established and institutionalized a disaster management program. To some extent, it is very prompt in its response and it is effective in reducing losses. Taking care of food needs of the affected population has always been a part of disaster management plan. Many of you would have read how food packets and water bottles are airdropped, whether it is tsunami or whether it is floods in Chennai or floods in Uttarakhand. These acute disaster management plans are reasonably well established and do work in India. However, we have relatively poor performance in terms of rehabilitation, including restoration of shelter, most importantly, long-term livelihood and earning capacity of the affected population. We will now move on to the chronic food insecurity and its impact of climate on this. India is a very precariously balanced situation in terms of groundwater, and we have not really taken care of this by overexploitation of groundwater in many parts of Tamil Nadu, Andhra Pradesh, and certain parts of Madhya Pradesh and Rajasthan. Groundwater is sinking and will not be able to provide even sufficient drinking water in many parts of the India, and that has to be urgently addressed. We have drought-prone areas which are well recognized, and drought-prone areas will have much larger duration of drought and larger frequency of drought under climate change. I have already alluded to flood proneness and its problem. Soil and cyclone erosion are also the major problems that will come in the way of chronic food insecurity. Chronic food insecurity and climate change are linked in many ways. First of all, agricultural production. There was an earlier allusion to reduced wheat harvest this year, and I talked about reduced rice sowing this year. We also have the ocean-related reduced fishery production, land degradation, water availability, all of which will reduce agricultural production. Apart from agricultural production and post-harvest management, prevention of losses, we also have loss of livelihood and income and rise in food prices, which we have been witnessing right through in the last 2 years. Both these will add on to chronic food insecurity and aggravate undernutrition. One of the things that I would like you to look at, as I said earlier, we were used to floods, and therefore we were used to cyclones, and therefore we have a disaster management plan. We can build climate change related disaster management plan on the existing disaster management plan. In the same way, India has been making enormous efforts to improve food security for a long, long time. People of my generation would always remember that we were living a ship-to-mouth existence. And thanks to Green Revolution, we were able to eliminate that nightmare and say India can produce adequate food for its citizens right from 1970s and 80s. It's only those who had seen and felt the 1950s and 60s can feel how much important this was. We also managed, therefore, when the next effort came, we focused on food security mission, which had two components. That is, one is food production of cereals and the other food production of micronutrient-rich vegetables, so that all foodstuffs needed for household food security and optimum nutrition is available not only at the national and state level, but also at the household and individual level, accessed and affordable. India invested heavily in horticulture in 2000 first decade. Why? Because with the shrinking land holding, horticulture can provide sustainable livelihood for small farmers and can be combined with food processing, storage, and transport facilities. It will improve the rural income. The focus shifted to production of low-cost micronutrient-rich vegetables. And finally, as a result of all this, please have a look. India today produces more fruits and vegetables than it does of cereals. Not that the cereal production has not increased, it has come up from 150 to 250, and really we are now a cereal exporting country. Okay, but again in horticulture, India has been wise. We have been investing not so much on fruits, but on vegetables which are relatively inexpensive and can be had to improve micronutrient intake. Wastage reduction, especially the R&D for wastage reduction, had immense amount of funding, not only from ICMR and ICAR, but DBT and DSIR. So today you have capacity to use either solar drying supplemented by electric drying or any other form of drying, so that whether it is potato, which can rot, or tomato, which really in glut season can be thrown on roads, which we did see some years ago, is no longer necessity. You can always dry it. Of course, for green leafy vegetables, that is not only the waste reduction and marketing strategy, but also help to the harassed housewife who wants to give a good, well-cooked, micronutrient-rich vegetable greens, but cannot do it in the limited time that she has. It is not that production alone we stopped. India is the first country in the world to provide subsidized food grains as a legal entitlement to 2/3 of its citizens. The National Food Security Act aims to improve household food security as an entitlement, not as किसी को देना है दिया था. Priority food households are entitled for 5 kg food grains per person per month, and poorest Antyodaya 35 kg per month. Did we have an example how this really saved so many millions from acute food deprivation? Yes, COVID epidemic. We had a lockdown. All of you had seen. Lockdown resulted essentially the entire urban areas shutting down all industries. Migrants in millions were trekking back home. There was no work available either in urban areas or in rural areas. And this situation continued for 3 solid months. The provisions under NSA were utilized to provide free food grains and also to provide 2 hot-cooked meals to all persons who needed them and came to facilities to access them between April 2020 to November 2020. That is the first installment. Then it went on November 2020 to November 2021. And then now, even now, November 2021 till November 2022. This single measure prevented acute food insecurity and chronic food insecurity during the lockdown months, especially among laborers and their families who had absolutely no income. And subsequently, when the employment improvement and emolument improvement were slow, went a long way in preventing any further increase in chronic undernutrition. And we need to really take this into account whenever we are talking about action plan for addressing the impact of climate change on nutrition security. What is our action plan? We need 3 types of action plans to combat climate change and its adverse consequences. Cut emissions. I have already alluded to cutting emissions from appropriate agriculture and animal husbandry practices and reducing the waste in vegetables using dry technology. This can substantially contribute to reduction in methane emissions from India. Then secondly, try to adapt to climate change, especially in agriculture, and in preventive steps that we need to take in terms of storage over time of foodstuffs. Finally, evolve and implement programs to mitigate adverse impact of climate change. Each of these interventions require investment in technology, innovation, financial, and human resources. We are really rich as technological workforce. We never lack capacity to innovate. In fact, Jugaad is a thing that we excel in. Financially, yes, we have problems, but so does rest of the world. And ultimately, we believe that we have enough and abundant willing human resources who will help. So I would like to make this distinction. Global efforts are critical to slow down the rise in greenhouse gas emissions and rise in global temperature. In that, India's contribution will only be very, very. So India will prepare itself to evolve and implement interventions to improve adaptations to climate change and mitigation of adverse consequences of climate change. Our focus in this presentation is on food security, nutrition, and health. What can we do? Dr. Mavlankar and Dr. Lakshmaya talked about every year get district specific met projection for 3 months. Give this to Department of Agriculture, and then depending on the collaborative effort between agriculture and med department, have as accurate and as regionally localized prediction regarding monsoon and the precipitation amount. Increase in drought prone areas will always adversely affect cereal production and animal husbandry. What to do under those conditions? We can't prevent drought. Please invest more in pulses and more in millet. They both yield coarse grains which are inexpensive and which will fight off hunger among the poor, and pulses which are essential and don't require too much water. This will therefore mitigate the economic hardship of agricultural farmers. Not that alone, both pulses and millet produce lot of roughage which can be fit to cattle. You don't have to depend on wheat and rice for cattle feed. Loss of livelihood and purchasing power in rural poor due to climate change will affect household food security and dietary intake. When persistent, these can adversely affect nutritional status. This is also a reality. But again, we have to focus on non-farm employment. Focused efforts on not only Narega, but also the urban counterpart, which is coming up now. Improvement in supplementary feeding through ICDS and MDM can help in mitigating some of the adverse impact on food insecurity and nutritional status, especially among the poorest segments of population and vulnerable groups. Unseasonal rains and increase in humidity will increase post-harvest losses and also cause contamination of foodstuffs such as, I have taken aflatoxin, there are millions. And both these, to some extent, post-harvest losses can be diminished by increasing use of electrical drying, especially for fruits and vegetables. Surveillance and monitoring are essential. They will take time. We have to be patient. Action plan for early detection and effective management of adverse consequences of climate change and food and nutrition security are implemented by 14 line ministries and institutions. Currently, Ministry of Health implements only 2 major programs. One is prevention and management of micronutrient deficiency, and the other is prevention and management of severe acute malnutrition. But they can play a major role to address the adverse impact of climate change by assisting the states to give them the criteria for identification of priority districts which may require advanced action for improving food security. What do I mean? Today, Niti Aayog, NFHS 4, 5, DLHS, AHS, everything gives you district-specific mapping of micronutrient and macronutrient inadequate districts in states. Select them and watch them carefully for climate change related adverse consequences. Monitor early warning signals for drought and associated food insecurity. What do I mean by that? Anganwadis weigh all under 5 children periodically, at least once in 3 months, and under 2 children are supposed to be weighed every month. These under portion tracker are immediately reported. Should it lie for compilation by a supercomputer at the end of the year? No. It should be analyzed every month at the district level using the simple methods that Dr. Mavlankar beautifully illustrated. See whether there is any rise in underweight children, especially in under 5. That is an early warning signal. Communicate to everybody. Ministry of Health and Family Welfare really has a pivotal role, therefore, in monitoring food security and nutritional status of the population for early detection and effective management of climate change related food insecurity, alerting other ministries as and when there is any increase in food insecurity or undernutrition. Initiate timely interventions to combat any increase in food insecurity and undernutrition, and provide critical nutrition education regarding importance of taking predominantly plant-based, well-balanced diet for optimal health. So, what are the triggers that Ministry of Health and Family Welfare can use? Request the Met Department for prediction for the identified small districts which have high undernutrition rate. Also talk about better implementation of NFSA and MDM and ICDS in districts where there is high undernutrition rates. Increasingly persuade everybody to use Niti Aayog's website district mapping, not only for aspirational districts, but also to all districts to assess nutritional status of children and adults and prevalence of anemia in children and adults and focus their intervention. And finally, this is truly aspirational, but we have to aspire. Each district should download the data and draw priority intervention based on portion to tracker and portion to targets. This will, to some extent, strengthen the ongoing nutrition surveillance and monitoring and help in early warning and reduce and minimize adverse impact. To sum up, currently India fares well at the national level as food secure. Country is self-sufficient in food production. It's one of the countries with fastest GDP growth. When the world is going on negative growth, 3% growth is commendable. MDG target for poverty reduction was achieved, and even now we think we can cope with SDG targets. Our major asset NFSA covers 2/3 of Indians to get subsidized food grains. And COVID epidemic has taught us that we can really make use of the NFSA to prevent chronic undernutrition from increasing. Currently, the average energy intake of Indian population is sufficient to meet their energy requirement. There has been over time some reduction in undernutrition. Priority will have to be given to evolve and implement action plans to adapt climate change and mitigate impact of climate change on food security. Therefore, even though the world has accepted that Asia and India will be the most vulnerable under climate change adverse impact, we ought to take hope and pride from this fact. In 2019, Asia constitutes 55.4% of food insecure people in the world. By 2030, this is FAO projection, it is not India government's projection. FAO believes that this numbers and proportion will shrink from 55 to 39. And therefore, even they believe India and Asia can do. And on that note, I will leave you and thank you. Okay, let me now take. I am now going to. Yes, Dr. Mavlankar, please check your statement. India is the first country in the world to provide subsidized food grain as a legal entitlement. Britain and many countries in the Second World War provide ration item to its citizens. Yes, agreed. But in peacetime conditions, when nothing was a problem, this remains the country that declared that we will now really supply on a peacetime with no famine, no anything. We'll provide on a perpetual basis legal entitlement for 2/3 of the population food. So many believe that it was not a very appropriate entitlement, but COVID proved sometimes we didn't know that it is going to come. But when it came, we saw that this measure helped us enormously. Next, 2 new messages. There are no more questions. Okay. Okay. Household, Dr. Nayar's question is, sorry, I am scrolling and I am somewhat not very enabled. Dr. Nayar, your question, household level food security measures. No, I'm not even sure that such measures exist. Because how do you educate a family on what is food security? It is really, really too much to expect at this moment. How do I get back to my? You
have to stop sharing the screen. At the top should be option.
I'm sorry. Stop sharing. I have to stop. Okay. If there are no more questions, Acha, Srinivasan has a question.
Only appreciations from
Okay, no,
all
it's not a
speakers from
question.
me.
Nobody has any question. And yet that's good. You know, because then I can tell you one thing. Very few seminars and very few webinars start on time and end on time. And therefore, we can take the credit that this started exactly at 10 a.m. and is over exactly at 1. I would like to thank all the presenters, maybe including me, for good presentations. We will upload all the PowerPoints. The recording will be available to all in YouTube for about a month. Okay. And from there, you can download it, and use it. Then, why did we choose this seminar as a topic? We discussed it in our governing body meeting. And I, for one, said, there is so much of pessimism and there is so much of apprehension as to what future will bring. COVID, climate change, warlike situation in Europe. Good God, what is the world coming to? I, for one, believe that challenges always bring out the best in human beings, especially their innovation. We have in the past faced the Malthusian prediction that, rapid population growth, good God, people will die. Asia will sink. Nothing happened. What happened was Green Revolution, and Asia now exports food grains to other countries. Certainly it is true for India. Then we started saying, oh God, Asian population explosion. What will happen? Their economic downturn will really kill them. No, much better contraceptive options, much better access to healthcare, much greater awareness among the population, and their awareness about need for improvement in quality of life. Today, we are no longer worried about population explosion. China, for that matter, worries a lot about its population, shrinking population. Of course, for Europe, it's done deed. You can't do a thing much about it. So, it is my earnest belief that sooner rather than later, the anxiety and worry about climate change would bring green technology available, accessible, affordable, and therefore limit, you can't reverse, but limit what was shown. Dr. Mavlankar showed it becomes yellower, from yellow to orange, orange to red. That progression perhaps would be reduced by available technology for green energy and green agriculture. Adapting to things is always part of human nature. Only thing is we were worried, will we adapt fast enough? I believe when given the stimulus, we will adapt and we will ensure that the world becomes a healthier, rather not splurgy, but very considering the entire ecology and not humans alone as inheritors of the world. This world is for all the people. All the planet is for everybody, including the rocks, the soil, the plants, the animals, and the people. If we come to that kind of coexistence, we will last several centuries in peace, and there will be improvement in quality. This need not be science fiction. It can. And on that note, may I say thank you very much. And with your permission, close the webinar. Thank you.